This is the technique for insertion of an iliosacral screw in the upper and second sacral segment using a closed procedure with the patient prone. A similar technique for fracture stabilization is used if an open reduction is performed. Access. This is a percutaneous technique, so access is determined by C-arm visualization. The preoperative X-rays and CT scan are reviewed to determine the size of the upper sacral segment corridor and if the sacrum is dysmorphic. The posterior pelvis must be well visualized in all views. If it is not, the percutaneous insertion of screws is not feasible. The indications for this technique are a fracture dislocation, or a dislocation of the sacroiliac joint, or a fracture of the sacral ala or sacral body, commonly transforaminal. Screw trajectory. Due to the obliquity of the sacroiliac joint, screws are inserted from posterior inferior and are directed anterior superior into the body of the upper sacrum beneath the sloped alar cortical bone and above the nerve roots tunnel. For transiliac transsacral screws, the pathway is located anterior-inferior in order to remain completely intraosseous and thereby avoid extruding through the alar cortical bone and the nerve roots tunnel. The second sacral pathway is consistently located cranial to the nerve roots exit at the anterior neuroforamen and on the inlet image just posterior to the anterior cortical limit. On the lateral image, the caudal anterior pathway is best seen. Patient and C-arm positioning, OR setup. The patient is positioned on a radiolucent table in the prone position, with radiolucent bolsters to support the chest and abdomen, allowing the pelvis to slightly flex so as to decrease the normal lordosis. The C-arm is brought into place and an AP, inlet, and outlet view must be visualized, as well as a lateral view of the sacrum. The involved leg may be free-draped if traction and manipulation are expected. The sterile draped C-arm is brought in from the uninjured side and placed in the outlet position. A stab wound is made where a line from the greater trochanter to the iliac crest crosses with a line dropped perpendicular from the posterior superior iliac spine. The incision should be down to the bone of the iliac crest to avoid the soft tissues deflecting the guide wire. The guide wire is inserted down to bone and a C-arm image taken in the inlet view to assess its position. For an iliosacral screw for the sacroiliac joint, it is necessary to place the guide wire almost perpendicular to the joint so that on the inlet view it will be aimed into the S1 body. On the outlet view, it is required that the guide wire be above the SI neural foramen and below the superior end plate of the S1 body. Alternating between the inlet and outlet view, the guide wire is positioned into the S1 body. The position for an iliosacral screw for a sacrofracture, or a screw to traverse to the contralateral side, will be demonstrated with an S2 iliosacral screw. A second stab incision is placed dorsal and caudal to the S1 stab incision. Again, using the C-arm in the inlet and the outlet position, the guide wire will be positioned correctly on the outer table of the ilium. On the inlet view, the guide wire for a sacral fracture will be aimed directly across the sacral body, so it will be able to enter the ala on the opposite side. The correct position in the outlet view is then ascertained so that the wire is above the S2 foramen and below the inferior end plate of S1. The guide wire is positioned into the contralateral side and confirmed on the inlet and outlet views. Once assured that the guide wires are positioned correctly, the length of the screw is determined. In this situation, the surgeon is using self-drilling and self-tapping screws. The screws are inserted with power until almost seated and then tightened by hand. The progress of the screw insertion is monitored with the C-arm to confirm it is following the guide wire and that the guide wire is not being driven further into the body and causing potential damage. It is acceptable to use a washer to prevent intrusion of the screw head through the outer table of the ilium and potential loss of fixation. When it is felt that both screws are seated, the C-arm is positioned in an oblique inlet view so as to take a tangential view of the posterior ilium and check that both screw heads are abutted against the cortex. When the position of the screws is confirmed to be acceptable, the guide wires are removed. A lateral view is obtained to confirm screw position.